So on behalf of the Global LMIC Cerebral Palsy Register Working Group, I, Dr. Ghulam Khandakar, would like to welcome everyone to the second webinar of the GLM CPR for this year, Key Informants Method. So those who joined the previous sessions, you would know Key Informants Method, or commonly known as KIM, is a novel method of identifying children with disability in resource-limited setting. We are very privileged to have Professor Mohammad Muhit with us today. Very rarely we get to hear about a method from an individual who actually developed that method. So it's a special night or day or morning, wherever you are, that Prof. Muhit, he and his team developed the key informants method during a national childhood blindness survey in Bangladesh and in Nepal over 20 years ago. Those who know Professor Mohit, he is an international expert on childhood disability and childhood blindness. He is the president of CSF Global and co-director of Asian Institute of Childhood Disability and Development, and also distinguished professor of international child health and disability at University of South Asia, Bangladesh. We also have a co-presenter, Dr. Mahmudul Hasan Al-Imam. Dr. Imam is a physiotherapist by profession and also a postdoctoral research fellow at the Sikh University, Australia. Without any further delay, I would like to welcome all of you to this session, and I will hand over to Professor Mohammad Mohit. Thank you.
Thank you very much, Ghulam. Thank you for the introduction and the kind words. Welcome, everyone. I'm very pleased to host this special webinar on key informant method on behalf of the GLM CPR working group. So I would like to welcome all of you to the webinar, and Dr. Mahmudul Hasan Al-Imam, who has been working and using this key informant method for quite a few years now with the Bangladesh Cerebral Palsy Register. So we will share our experience, but most importantly, from Global LMIC CP Registry, the main objective of this initiative is to work together to have a system developed in all these LMIC countries so that we can reach these children with disability in these countries through a method which is cost-effective, which is efficient, and which can be implemented in different LMIC country contexts. Sorry, a bit of. So today's session, we will divide them basically into three different parts. The first part, we will key informant method, its development, the way it is developed. Can you hear me? Hello, can you hear me?
Yes,
okay,
yes, we can hear you.
All right, yeah. So this key informant method, its background, the way it was developed, we will discuss those with concrete examples. And in the second part, we will discuss about the use of key informant method for cerebral palsy, particularly to find those children, to setting up the register, and how that can help us in conducting research and advocacy and public policy and getting the population-based data on the epidemiology. And in the third part, we will actually deliver the overall kind of know-how, step-by-step procedure, how to set up a key informant method based register for the children with cerebral palsy in those countries, and what needs to be planned beforehand, how to implement that, what kind of resources, human resources and other resources are required. But for this whole webinar, I would like to make it a more interactive, and we will use some interactive survey during the session. So I would encourage everyone to take part in those interactive surveys. Also, I would encourage everyone to write your questions in the chat box. Some of the questions we will address during the session, but also after the session, we will summarize all the questions and email every participant with all the detailed relevant information related to those questions. And the session will be recorded for future use for other kind of training or other purposes for the Global LMIC CP registry. So please participate, and we will have some opportunity to get questions from you guys and try to discuss and address those questions. So at this stage, I would like to invite Mahmoud to do this survey. I would also like to welcome Professor Nadia Badawi, who just joined us. So
Thank
welcome, Nadia.
you.
Thank you, Professor Mohit. So for the first thing first, could you please complete the registration form by scanning the QR code below so that we can reach out to you later and share our resources, please? If you can't scan the QR code, please visit www.multimedia.com and enter the code 7813741.
So you can either use the barcode or use that code above the numbers.
Has everyone scanned the QR code? We will change the slide in 15 seconds. Now I'm going to change the slide. So now let's have some quick surveys. So what are the challenges do you face in identifying children with disabilities in low and middle income countries? Please write in 2 words. Again, please scan the QR code. And if you can't scan the QR code, just go to mentimeter.com and enter the code 989576689.
So what are the challenges in reaching children with disability, finding them? Have we got any response yet, Mahmoud?
Not yet.
Hello, sorry. Good morning.
Good
Yeah,
morning.
so I sent the registration and it seems please wait, the presenter hasn't changed slides yet. To move me to what challenges do you face?
You'll have to scan the QR code again. Please scan the QR code given in this slide.
Mahmoud, you have to go back to that slide again then to be able to scan it again.
No, I think he's trying to answer the question. What are the challenges do you face?
Mahmoud, I think that the slide is frozen. If you could unshare and share the slide again, please.
Okay.
Sorry for the technological hiccup. Quite challenging to operate from different continents.
Can you see my slide now?
Yes.
Oh, sorry for the inconvenience.
So you guys can try once again. Either scan the barcode or use the link.
Yeah, so now it sent me to as to whether key informant, is feasible in my country or jurisdiction where I am.
Right.
I couldn't, answer the question what
Okay.
challenges. Yeah.
Mahmoud, better we skip this bit, Mentimeter. It's definitely not
Sure.
working. So if we have chance, we can do it later. Let's move on.
Yeah, sure. So I think, Professor Mohit, please continue your session. We will try to use the Mentimeter later in that case.
Mentimeter, yeah. Try to fix it in between.
Yes.
Then
Thank you.
thanks, Mahmoud. So not moving the slides somehow. When we are sharing, causing some.
Prof. Mohit,
Yeah.
I think could be bandwidth problem. So if you um, open your slide and don't go to the presenter mode, just so you can change from the slide from the panel on your left.
Right. Okay.
Yep. I think the fonts are big enough so we can see it properly on our desktop.
Okay. It's working now.
Yep.
So guys, sorry for the initial hiccup. About what I was mentioning in the beginning, that as practitioners, we are always faced with the fact that in low and middle income countries, we don't have a well-developed health system. So people who are living in the rural area, people who are coming from poorer socioeconomic background, services are not available in those areas, and we cannot reach those. So in the schools, you will not see those children who are affected severely by disability. In social gatherings, you won't see them. And the main reason is there is rampant stigma around the issues of disabled children and also in disabled adults. There is also a lack of awareness in the overall in the general community, but also even with the professionals or practitioners about the magnitude of the problem. A lot of people don't even realize that thousands of children are affected by severe disability with conditions like cerebral palsy. And obviously, there is lack of appropriate infrastructure, health system management, and documentation, which contributes to the challenges. Health financing is a major issue, and the planners have to deal with that challenge and allocate resources for more important or apparently more important conditions. Health budgets are also limited in those countries. One of the main challenge of identifying and subsequently providing treatment, therapy, and services is the lack of skilled personnel. The sheer number that is required in those countries with large number of children with disability, we don't have the institutions or the professionals in that number in those countries. So we need to have an alternative method which is easily implementable in the low and middle income settings where the national health system doesn't cover the entire country in a systematic manner. We have to find an alternative way. It has to be locally appropriate, and it has to utilize local resources as much as possible. And the other long-term aim should be whatever we do to study a particular condition, be it cerebral palsy or childhood blindness, whatever research we conduct in the community, we should always think about empowering the local community in as many ways as possible so that we end up having a system which will continue to run even beyond the study or survey or research period. So facing with those challenges, we were trying to identify blind children in remote rural areas from Bangladesh. And that was at first time a big national study, which was planned by the London School of Hygiene and Tropical Medicine, where I used to work at that time. So I was leading that team to conduct that national childhood blindness study in Bangladesh. And then we faced with all these challenges. There are no cost-effective ways to reach all these estimated number of children in different districts with a short period of time with limited resources. So we started looking at the community, analyzing the community's existing structure, social structure. So there was a bit of initial exploratory research using qualitative research methods, anthropological research methods, simple but effective techniques like focus group discussion with different stakeholders. And we identified that every society, they have their own system of communication and sharing information among themselves. And that's been there for every community. They have their local leaders, they have their social elites, they have sometimes religious leaders. In some communities, young students, they work as volunteers on various issues. So for the first time during this study, we realized that that can be a huge social capital, that network of people who are using their own method of communication channel so that they can spread information about health system, about education sector. So people ask for information to those particular people. So we did a mapping and we identified some particular group of people in every community who are the key informants. And during the childhood blindness study, using those key informants, we tried to develop this system, which is graphically represented here. First, to go to these people, identify them, map them, and provide them with information. Create awareness among those key people and in the community in general. Provide specific training to some of those key informants who are identified as effective and who are willing to work with the project. Provide them with the training how to identify children with that particular condition, and then organizing a special medical team to visit the community, and all these enlisted children who are suspected to having this health condition, they are examined by the professional team and systematically data was collected. So that was the beginning of key informant method by using local volunteers, providing them training, motivating them to identify the children who can benefit from services that we service providers are trying to bring there. Within a very short period of time, these key informants, they identified in the first phase, they identified more than 2,000 children. And they were examined. These are all suspected bilateral blind. Blindness is a relatively rare condition in children. So it's a quite large number. So far, it is the largest cohort of blind children identified. In Bangladesh, so far, in different phases of this program, we have identified 40,000 blind children by providing training to 22,000 volunteer key informants from different communities of the country over the last about 10 years. So that's the scaling up of the initial research project. First 2-3 years, we identified 3,000 children, more than 600 were blind from a treatable condition, cataract in both eyes. So they were treated, the service was provided, and the whole cycle was completed. So every community, they saw that we came to the community, worked with them, then we identified those children, assessed them. Those who were treatable, they were referred to eye hospital and got the treatment. Those who were incurably blind, we linked them with the rehabilitation and education system. Subsequently, this key informant method was used in many other countries. I was a faculty at the London School of Hygiene and Tropical Medicine and doing this research and also teaching these methods to the students, postgraduate students we had every year for the who are attending the Masters in Community Eye Health. And there's a module on childhood blindness and infectious eye diseases. So it became the kind of curriculum for many years. So all these master students, they were introduced to this component. And every year, 2-3 master students at least every year chose to do a pilot study using the same methodology. So in the subsequent years, we saw in many countries, gradually, mostly low and middle income countries, they used key informant methods successfully to identify children who are blind. So how does it work? What is this key informant method? The main thing is you have to go to the community, map the community. You can map the services, who are the service providers. You can talk to them. You can have focus group discussion with the service providers locally. You can have community leaders. So bring them together and explain them the main mission of the team. We are working on children with disability and we need your help, and we can provide some help to find these children together. Because in many communities, these children are hidden, and it is very unusual to see them in service provision places or in social gatherings. So we did this process several times, and we did a study to look at the effectiveness and the process documentation. It was published, and we found that 98% children can be identified by the 98% sensitivity to identify them, and up to 85% of all affected children can easily be identified. And these studies are mostly focusing where blind children, hearing impaired children, children with cerebral palsy, children with other physical impairments, and epilepsy. And there was also variation in the effectiveness. Like for hearing impairment, it is not very effective because the whole process is based on the understanding that you can have some visible changes in the body organ or the functioning, which can be communicated in simple language to the community members, and then they can identify them. For hearing impairment, it's a bit challenging. Sometimes externally, you cannot see anything. Whereas for physical impairment, it's quite easy for key informants to identify children who have mobility problems, who have other problems. They wouldn't know which one is due to cerebral palsy or other causes, but they would know the physical impairment and they can refer them for the clinical assessment. So there are strengths and limitations, but we have to remember that from a research perspective, say survey method is the kind of gold standard. And to do a survey for a condition which is very low prevalent, for cerebral palsy, say 3 per 1,000 children. So to identify, say, 300 children, you have to do a survey of thousands and thousands of children because it is so low prevalence. Any relatively rare condition is difficult to get enough numbers, large sample size for research using the conventional gold standard survey method. And to do it in a larger population, to find few children with disability, key informant method gives that opportunity where you don't have to examine thousands of thousands normal children, healthy children, to find only few who have some sort of health condition. It also empowers the local volunteers, families, and children. And that has a long-lasting effect, which we have already seen in Bangladesh and in some other countries where we have been working over last 5-10 years. Now those communities are more aware about these children. Even without our volunteer team, key informants, or our project team members going to those communities, any incident cases, any new cases when they identify, now they know where to refer, what could be done for these children. So that is a very powerful element of working through key informants. You actually leave something behind in every community where you go. Referral for identification of incident cases beyond project timeline, that can be continued if it is done properly in partnership with local service providers. And also the cost effectiveness, it is way cost effective and cheaper than conducting a full-blown survey in the community as a door-to-door survey or any large survey methodology could be followed. That would be very expensive. Limitation, we cannot find 100% children by using this methodology. We will miss some, those who are very young, those who have very mild impairment or disability, they might be missed. But also from our experience, because it's an empowering process involving the community, during the study period or even in the first round, we may miss up to 20% of those children. But half of those children eventually be found by our key informants and they will be referred. So up to 80-90% you can cover through the initial work and subsequently others will be found. So that's the limitation. There are diverse use of key informant method. As I mentioned already, studies looking at the population-based prevalence of any condition. This methodology can be used and it has been used in over 20 countries for visual impairment and blindness in children and doing research to find the prevalence and the causes and etiology. Similarly, for cerebral palsy research in low and middle income countries, CSF team and the global LMIC cerebral palsy registered team partners. We have already published several research based on key informant data. Service provision is a huge advantage, which makes it more valuable than other research methods, because here from the very beginning, you have the mapping of the local service providers. You can plan for future service delivery, and you can plan with local stakeholders. Community-based screening and early detection, time to time, in every district, in every community, in a campaign mode, within 6 to 8 weeks, about 2 months, you can go into a sub-district, you can go through the whole process, the steps of key informant methodology, and you can do the community-based screening of those communities within 2 months. Mapping of referral services is part of this whole process. And once you get this initial data, that gives you a strong indication about the estimated prevalence. You can calculate the estimated numbers for each locality, each district or sub-district, and that can become a very strong advocacy tool. You can then go to the government ministries, social welfare, health, education, and you can show your evidence for more services, more research, and more inclusion. Community awareness raising throughout the process, because it is delivered at the grassroots level, because it involves local communities, it creates a huge awareness in the community as part of the whole empowering process. So in disability research, we have done it. I have mentioned already that we looked at initially blindness, but also to hearing impairment in children, epilepsy in children, and we did some validation of the process and documented all the steps through those projects. So adapting key informant in cerebral palsy research. From around 2000, 2003, we started this key informant use. By 2010, we have already used it for 4 or 5 different conditions. And one of those studies gave us the idea that vast majority of children having physical impairment is actually children with cerebral palsy. So why not focus on those children and adapt this methodology by focusing on cerebral palsy? And we developed all these training materials for community volunteers, focusing on neurodevelopment and also particularly focusing on cerebral palsy. We started this work focusing on cerebral palsy using key informant around 2012-13 with a pilot project, and then from 2015, we established the Bangladesh Cerebral Palsy Register, which used extensively this key informant methodology to identify this large number of children and subsequent programs. So the steps, main steps, which will be described later, Mahmoud will describe in detail about the steps, but basic concept is identify the right people in the community. As you can see in this graphics, that in Bangladesh, as I mentioned, religious leader, local social worker, political leaders, women health workers, women leaders, all these groups, NGO workers, they were identified at the community resources and they received the training and they worked as the key informant. One of the things for key informant is that these are the people who live and work in that community. So through their occupation, through their job, most of them, they're the first line of service providers. So school teachers, they meet children every day and their parents. The health workers, they visit all these households with the primary health care uh, services. So those are the key informant. They have a social role. They have an occupational or vocational role. They all live in that community and they are the source, traditional source of information and information dissemination. Once they're identified, they're trained, they're provided with a half day or 1 day training and ongoing support, given 4 to 6 weeks time to work in their community during their social and vocational role. Through that, pass this information to the community and start listing all these children identified. Once they're identified, then the medical team goes there and assess, and you start getting the data, and the system is up and running for an effective register for children with cerebral palsy. Globally, already KIM has been adopted in 22 different countries, mostly in Asia and sub-Saharan Africa, mostly in low and middle income countries. There are several studies done in those 22 different countries in the region, and it's always growing. We are already in partnership with some other countries and organizations to roll it out in other countries. There are challenges, and the common challenges of implementing a key informant program. Lot of trained KIs in the long run may be lost to follow-up, partly because some of them are there because of their vocation and work. So an education officer or a government school teacher, in few years' time, they're transferred to any other location. So for the long-term follow-up, some key informants will be lost, but their effectiveness will not be lost. What they know, they will continue to use that knowledge in their new location. Keeping KIs motivated is a challenge because many of them, especially for health worker, development workers working in the grassroots level, they have their ongoing main program, but also various vertical health and social welfare and disability programs are introduced time to time. So you may have a health program, but there is a special program delivered by the same health workers. They are working on trachoma. In some places, it's malaria. In some places, it's other diseases. Sometimes special immunization campaign. So they're always busy. It's difficult to keep them motivated. But the advantage is our main work is done during that 2-month window period. It's in a campaign mode. So when you introduce into their community, within 2 months, you try to keep them motivated and get the job done. And then for the long-term motivation, depending on the different type of key informants, you may gradually develop strategies to have a continued relationship and keeping them motivated. But in the campaign mode, wherever you go, within 2 to 3 months, you complete the cycle and you keep them motivated during that time. In some places, even they use extra monetary support, which we wouldn't recommend or encourage unless it is really necessary, because once you introduce extra incentive, that studies show that reduces the internal motivation. It increases the external motivation for a shorter period of time, but the internal motivation is lost. Meaning, if you once introduce the incentive, in future, you will get no work done without new incentive. Whereas if you can motivate them internally, they will continue to work time to time on different disability-related initiatives that you and your organization wants to deliver. So for the long run, it's better not to introduce the monetary incentive for all these short-term tasks. High number of children identified by the key informant in every location, every places. Usually, the way we plan, it's for a population of, say, 100,000 people. Out of 100,000, that would be a sub-district level administrative unit in a low and middle income country usually. So you take a population of 100,000, maybe 30 to prevalence. You will find about 100 children in that small unit, which is the primary administrative unit in any country. So in Bangladesh, it is not even sub-district. It is below that level is the union council, which will have a population between 50 to 100,000 with a child population. So in that area, with the team, which Mahmoud will describe in detail, and with the different steps, you complete the process within 2 months. In some places, there is low attendance of children at medical camps. Depending on the cause, there are remedies. In some places, it's really remote areas. You have to have maybe more camps in going further, closer to their homes and villages. In some places, they may need some extra support for the transportation of children to the camps. So those are the issues which will be dealt and discussed in detail by Mahmoud. At this point, I hope that gives you an overview of the development of key informant and use of key informant in different communities, different countries. Up to this point, if you have any question, I would like to invite anyone having any question. You can type it in the chat box, or you can raise your hand here, then we can. Any question or comment? Can you hear me? Okay.
Yes, we can.
All right.
Yes.
So any participant in this webinar, do you have any experience of similar process or similar things you have done in the past using local volunteers finding children with disability? I'd really like to know any other similar but not totally same method if you have. Or any other question, if you can type it in the chat box. Gulam, would you like to mention
Thank you,
anything
Prof.
particular?
Mohit. I think we have a question from Abir Masad. Prof. Mohit, I'm giving it to you. How to decide on the KI selection?
Okay, thank you. Thank you for the very
It seems actually we have Prof. Mohit has just dropped from this meeting. So while he's away, so Abid, this is an excellent question actually. In Prof. Mohit's absence, I'll try to fit in as much as I can. So this is a very important step, the KI selection. And I think later part where Prof. Mohit was saying that try not to.
my back.
You're back.
Oh,
Prof.
sorry.
Mohit,
Yes,
I
please
was taking the
continue.
opportunity
Gulam, please
to fill
continue.
in your absence.
Please continue.
Yeah. So try not to incentivize the KIs, which might backfire through the process. So main motivation in KI selection is that people's willingness to give back something to their community. So as a human being, even in low resource settings and very impoverished societies, we see that KIs are extremely motivated to do good to their community. And that's the inner motivation you have to nurture and look for. And that could be anyone, I think, in that social dynamics with connections and who has the whereabout, have the idea about the whereabout of those children with disability or cerebral palsy. For example, a religious preacher in Bangladesh actually knows, or imam we call, knows about a child with disability in a very rural community because their parents go to the religious preacher for holy water. And it could be different in your setting, could be a witch or a sorcerer actually who does magic, and although it's very stigmatized, but that person will know actually which house actually has a child with disability, because they might have went to that person for some support at some point. So you have to be innovative, and it's not that one size fits all. It's like very dependent on your particular community dynamics. Thank you, Prof. Mohit. Back to you.
Thank you. Can you see the slides? Can you see the slides?
No, we can't see the slides.
No.
I think there are some questions as well, Prof. Mohit, if you like to take. Is there a structured questionnaire for the informants or observation tool to identify the kids?
Okay, yeah, there is. There are a few set of questionnaire or data collection forms, which again Mahmoud will share. So for the BCPR and now for the GLM CPR, we have a standard data recording form for all children with cerebral palsy, and all the details are covered there. For the key informants also, we have some forms where we collect some demographic data and try to summarize those demographic data and the contact information. Any other question?
I think no questions so far, and thanks to Thembi and Nadia and everyone for your kind words. Prof. Mohit, I think,
Yeah.
would you like to move to the next section or session?
Yeah. Can you see the
Yeah.
slides now?
I think Mahmoud, we can see
Can
slides.
you,
Yeah.
Yes.
can you see the slides?
Yes. It's okay.
Okay. So some details about Bangladesh Cerebral Palsy Register. It's a population-based surveillance established in 2015, 17 sub-districts of 13 districts, and key informants trained over 3,500, and children registered so far over 4,000. Similarly, we did another register in Nepal Cerebral Palsy Register. It was also done in the same way at the population level, and it's a population-based survey conducted in 2018. 6 municipalities of Gorkha district of Nepal, nearly 200 key informants trained, and nearly 200 children were identified during that short period of time. All these results and the methodology has already been published, so you can get the references. And after the webinar, also we will we will tell you about the resources available and the support available to get more information. Similarly, we did a study in Indonesia. It was also population-based survey in Sumba Island. That's a small island about 1 hour away from Bali. That remote island, we trained about over 600, nearly 600 key informants, and 130 children with cerebral palsy were identified in that tiny island. So if you look at the children who were identified using this key informant method with population, with community-based community volunteers, these are the children they identified, and of them, nearly 60% were male, boys, and nearly 40% were female. Mean age of diagnosis was around 4 years and 6 months. Spastic type of CP were more, about in 80%. GMFCS level 3 to 5, between 50 to 80%. And of them, nearly half of them, usually they don't receive any services in those settings. So this is just an indication, and it shows that through these cerebral palsy registers, through using this key informant, we are reaching children in rural areas, remote areas. Half of them, sometimes 60, 70% of them, they were visited by any doctor or seen by any rehabilitation specialist or therapist. And we are finding those children who have severe disability, spastic form of CP, and higher level of GMFCS classification. So that shows that this is an effective method for reaching the children who are in need of the services the most. Questions, some we have discussed already. So now we will move to the next stage, which I think Mahmoud will elaborate more, how to actually conduct the key informant training, how to find them, where to find them, what are the training required, how to support them during this key informant survey, and how to complete every step in a systematic manner so that we can find large number of children and provide them with the services. So Mahmoud, please, I'd like to welcome you for the next part. Thank you.
Thank you, Professor Mohit. Let me share my screen, please. Can you see my screen?
Yes.
Thank
Yes,
you.
we can.
So there are actually 7 key steps that I'll be describing in the subsequent slide. The first one is planning for a KIM. So before we begin, we have to ask few questions. What is the purpose of this KIM? What do you want to measure in this KIM? What human resources do I have for this KIM? How big is the KIM going to be? Who will coordinate this KIM? And who will analyze and prepare the report? So once we have answer to this question, then we'll have to establish a advisory group. And this advisory group should include policymakers, researchers, DPOs, local NGOs, and community stakeholders. After establishing advisory group, we'll have to attain necessary permissions like ethics approval or local government approvals. Then we'll have to recruit the field team. The success of a team depends on a dedicated full-time team. We'll need a full-time project manager and a number of KI coordinator or community mobilizer. The exact number of community mobilizer will depend on the size of the team. Then we'll have to train the community mobilizer on the purpose of this scheme, how to organize the assessment camp, and how to train the key informant, etc. We'll have to map the service provider within the project site. This is very important because once we have identified the children, we'll have to refer them to a relevant service provider. Once we have determined the geographical coverage of KIM, we'll have to spend some time in each locality to share the study information, to sensitize the local community, as well as to determine the obstacles, as well as and facilitators to help us with the planning. The next step is identification of key informant. As Professor Mohit said, the KIs are people who live and work in the local community, and they have social role and who are therefore likely to know the local context as well as the people we are looking for. The KI should be well-trained, reliable, mobilized for the cause, and motivated enough to work voluntarily. And they should be willing to support children with disabilities. They should have good communication and networking skills. Some example of KI could be a teacher, religious leader, NGO worker, or community health workers. Community mobilizers are responsible for identifying and making a list of potential KI. The template should include very basic information, including name, gender, education, occupation, address, and contact number. Comprehensive training and retraining for the key informants are important for successful identification of targeted children with CP. The training should be conducted in person for a half a day, including 20 to 25 participants per session. We'll have to use flip charts, role-playing activities, and audio-visual materials for the better grasp of the content. And we'll have to share handouts and blank child list form for the future use. The training session for a CP register should cover the objective of the session, the overview of CP, including definition, risk factor, sign, symptom, and rehabilitation need, how to identify children with CP with easily recognizable features. It is also important to explain the stigmas around CP so that the KIs understand that most of these children remain hidden, Also, the steps after identification, such as medical assessment camps and referrals, should be discussed during the training session. After the training, key informant should actively look for suspected children with CP in their communities while doing their own work. Once identified, they should record the suspected children in a structured list. They must write down the contact information of the suspected children. This is very important for retracing and assessment. Once completed, the key informant should preserve the list in a safe location and hand over the list to community mobilizer. KI might need to help the community mobilizer in retracing the listed children. Last but not least, KI should motivate the parents of identified children to attend medical assessment camp and access the services if referred. After the training, key informants are given 4 to 6 weeks to identify children from community. To facilitate the identification of children with CP, KIs should share the study information with their communities and relevant stakeholders. Once identified, KI should visit the household of children who probably have CP to talk to their parents and observe their symptoms. If suspected, KI should prepare a list of children with suspected CP. KI should clearly understand that the medical camps are for screening and referral only, not for indirect treatment. False expectation can cause confusion and frustration. KI should also report any concerns raised by caregiver of listed children back to the community mobilizer. For example, if caregiver feel they do not have time to attend the camp or the transportation cost is too high for them to travel, they should relay this information to the community mobilizer so that appropriate steps can be taken, either organizing smaller camp in a convenient location or assessing those children at their household. The KI should record child's name, age, gender, perceived disability, primary caregiver names, contact details, and if the child needs any assistance to attend the camp, etc. Community mobilizers should routinely follow up with the KIs to collect and compile the list of suspected children with CP. Step 6, determining camp location and inviting caregiver of children with CP to attend the medical assessment camps. While deciding about the camp location, we'll have to make sure that the location is accessible to all children, convenient for majority of the families, and familiar to everyone. We can organize the camps in schools, government offices, or hospitals. We may need to visit child's household in some cases. We'll have to obtain consent, preferably written consent, prior conducting assessment or collecting data. Once consent is obtained, we'll conduct clinical assessment for a confirmed diagnosis and detailed neurodevelopmental assessment for rehabilitation needs. The assessment data should be collected using a standard case record form. Here we can see the case record form of the Bangladesh CP register. The final step, service need assessment and referral. The medical assessment should be conducted with a multidisciplinary team. The clinical team should be comprised of a pediatrician, physiotherapist, or occupational therapist. And the non-clinical team might include community mobilizer, community rehabilitation worker, counselor, and research officer. We might need specialists like ophthalmologist or ENT specialist if the project budget and objective allows. Each team member should have predefined roles and responsibilities in the camps. And here is the final step, service needs assessment and referral. Based on the assessment findings, we'll have to decide whether the children have any unmet needs, which could be medical, rehabilitation, or educational needs. And based on this need, we'll have to refer these children using our referral network. While referring, we should explain the referral procedure and expected outcomes. And we should share contact information of the service provider and any associated cost. We should also inform whether the cost for accessing services will be covered or not. And we should share contact details of key personnel for future use. So that's all from me. I would like to invite Professor Mohit to continue the rest of the session. Thank you.
Thank you, Mahmoud. Any question at this stage? Either you can speak, unmute and speak, or you can send a comment on the chat box. Meanwhile, we have got some questions previously. One question was, is it good to do a hospital-based survey instead of a community-based survey? Hospital-based surveys are good starting point. It is easier to implement using the existing resources. You can gather data from the walk-in patients, but it will obviously not give you any population-based prevalence figure, because you're not getting all these kids from one defined geographic population, and you're not covering the entire population to get a population prevalence. Other data which we collect in the CP register, the type and severity of children who are attending, that data is likely to be also biased if you collect it only from the hospital, because those who are living farther away from hospital, they are less likely to be in the hospital data. Those who are having severe disability, they might be less likely to come and visit the hospital. Those who are the poorest, they are likely to be missed out if it is just the hospital-based data. So there are advantages and disadvantages of both methods, and both methods work in a different way. Any other, some questions we have? Structured questionnaire, we have already mentioned that we have a very well-structured, well-validated data collection form for the CP
Mohit,
register. Yes, please.
sorry to interrupt. I think it's Aaron from Malawi, if I'm not wrong.
Yes.
His question is, I want to find out what could be a better ratio of KI to populations in their community.
Yeah, thank you. In Malawi, actually, one of my students from the London school, he did a study on childhood blindness and key informant method used in that place. So in Malawi, you also have similar structure, which can be very effective to utilize key informants, and there are some studies done on that. Ratio-wise, the more is better, but usually for 100,000 population, you should train at least about 50 to 100 key informants. That's the rough number we use, but it depends on the population density. It depends on the area, size of the area, and the time you are spending in that area. But 100,000 population rule of thumb is like about 50 to 100 key informant. At least you can train even 200 in smaller groups. Number of children identified because of the key informant method. First few rounds, once you finish, you will get data from 2-3 spots, and you can estimate the estimated prevalence number using the key informant. And that will give you the target numbers in subsequent round of key informant in surrounding places. So then usually 1-to-1 ratio. So if you can estimate in that area around 100 children with cerebral palsy will be found, you should train at least 100 key informant. Is that right, Mahmoud, practical experience-wise? So 1:1 ratio, number of key informants trained and number of children found. Does it answer my question, Ghulam? Your question, Malawi thing?
Yes, I think it's great. And I think Thembi is online as well. So Thembi has recently done, Thembi and team has done, came in Malawi. So if you allow, Thembi, would you like to share your experience briefly?
That would be great. That would be great. Yeah, please go ahead, unmute and share your wisdom.
Thank you very much, Prof. Mohit and Prof. Ghulam. I think we have learned so much from the key informant method, and what we have done, what we did in Malawi, we were not sure how we're going to do it. But I think after going through and adapting the key informant method that you designed, we were not as ambitious in terms of the number of key informants that we would train. So because we're not too sure how it was going to play out. So initially, we trained 10 key informants, and they went through a day's training, which Aaron, my colleague, took them through. And after that, we gave them all the reading materials of what to look for, and we sent them out into the communities. And because we were navigating, it was the first time for us, we gave them at least 2 months to identify these children in their communities. So what happened was, as they were doing their normal work, they would, if they identified children with CP, they would document them, and then they would send them to us so that we had a record of these children. And when we had planned our CP assessment camps, we were really overwhelmed. We had screened, I think, almost 700 children, and out of those we identified 563 children with cerebral palsy. And this was just with the 10 key informants that we had trained. So we really found this as a very, very powerful tool in low and middle income country settings, where it's, as you rightly said, cost effective and also empowering the people that are in the communities. So we used already community health workers. We didn't go to the religious leaders or political leaders. We just used community health workers that were existing in our communities. Thank you.
Thank you very much, Thembi. That's really insightful and encouraging to know. So, any other comments?
Prof. Mohit, one from Samuel from Ghana. And very interesting questions. What happened to the scattered settlements like Ghana, especially the hard-to-reach communities?
Yes, very good question. Thank you. For the Ghana, or in many, I think, African countries, compared to South Asian or Asian countries, the population is scattered and distributed in a different way. So, although it is scattered, the advantage is we only work in a population of 100,000 so even 50,000. So although nationally, if you look at the map and the population distribution, the villages or the communities are farther away from each other. But I guess the primary administrative and health unit, whatever you have, that would have a population of between 50 to 100,000. It could be a health district. So you focus on one health district or area, and in that area, you work in the same way. Other trick is, because of the dispersion of the population, you train the key informants in a batch of, we usually do in 20, 25 people. Rather than bringing all these 100 or 200 key informants for training in a central location, you can actually send the training team to conduct 10 sessions in 10 different villages within that district where you are trying to plan. So that's how you even plan also locally and try to decentralize as much as possible all the different activities at the minimum at the local grassroots level, so that it's delivered even in the village setting. We have some more comments. I want to find out what could be a better ratio. Okay, that's been answered. There are more resources on our website and GLM CPR website and CSF website for further detail. And as I mentioned earlier, that our team here will be happy to send you the links of further information if you need more. Yes, scattered settlement Ghana, we have answered. What about data collected from institutions working with children with special needs? Can we collect such data alongside with data collected from the community? Very good question, and that is the ideal scenario. And I guess even in Malawi, with 10 key informants, the reason you got so many kids, because I think there are already existing kind of network of these children, either through rehabilitation program or through the hospital network or something, where they actually just connected this project with those existing systems. Only that way you can get so many children with only 10 key informants trained, which is a wonderful result. So everywhere, when you start, it's better that's why at the beginning you do that social mapping and service mapping. So start with contacting with the existing hospital, resources, schools, and collect those data alongside with your key informant volunteers. And if you do both at the same time in the same geographic location, then you will get the best population-based representative data, which can be used for further advocacy and policy. What we do in Ghana is to create boot camps and link the communities to the boot camps, community-based volunteers, therefore linked to those boot camps, trained and moved. Yeah. Samuel, if you can share your Ghana experience with all of us, I think that would be better to hear it from you.
Thank you
Samuel?
very much.
Yes,
Yeah, thank
please.
you very much, Prof. Yeah, so in Ghana, what we do is we identify areas that we want to, on that such particular, research. And then once we identify, based on how scattered they are, we have something called sub-districts. So each sub-district will become a boot camp.
What's the
Then we will
population of
link,
an average sub-district, if I may ask?
yeah, some can go as far as 8,000, some 12,000, depending
Okay,
on the total population that is there.
okay, good.
So once these boot camps are being created, we train the community-based volunteers and then link them up to these boot camps, depending on the geographical location of the community-based volunteers. So after training, they are allowed to move into the communities, search for suspected cases, and link them to the boot camps. And then in each of the boot camps, we have, a team visiting those boot camps. So that is what we do. And for, once they link the suspected cases, the health professionals are able to do further, assessment.
Perfect. Thank you, Samuel. So basically, you are doing your own key informant methodology using your own population challenge, that it is a scattered population. So you are sending your team and working inside that community. So that's all about the key informant process. And as I mentioned, key informant method is not a kind of blueprint. It's more like a process. If you follow those steps, but modify them and adapt them according to local resources and consideration, it works the best when it is adapted for the local context. Thank you. Any other comment, any other different ways of reaching children with disability in other countries? Any experience? Please feel free to unmute and share. Okay, I think we should move on. Can you see the slide?
Not yet.
Not yet? Hmm. Sorry. We're trying to do it from two places, becoming a bit cumbersome. I hope it's going to work. Can you
It's
see it
moving.
now?
Yes, it's
Okay.
working now. Thank you.
Okay. So to summarize what Mahmoud has already described, that the main thing is you have to understand and map your own community. Understand the local system of information dissemination. And also you have to map existing service providers and bring them together, develop this method, provide them with simple but effective training on how to identify children with cerebral palsy in a rural village in Africa, in Latin America, in South Asia, wherever. So that's the whole cycle. During the project or the activity cycle of 2 months in a particular community. But we have to remember, and I'm pleased that many of the participants, you also mentioned that advocacy, long-term advocacy could be a task effectively done by the key informants, both at the local level, but combined together, they can also become a voice at the national level. So that is an important task. Also, the academic, professional service providers, doctor, pediatrician, physiotherapist, those who are involved in delivering this key informant method and doing the assessment of children, establishing the register, that is also a wonderful multidisciplinary team, which during the project will have lots of practical experience of working together, will have the opportunity to see how these children live in their own village, in what context, what are the barriers. As a professional, sometimes we're trained actually to look at the impairment, provide them with the treatment. But during this sort of activity, I think our experience showed that this multidisciplinary team gradually becomes more interested in doing further research. Those research are kind of next stage of research where they can look at the etiology, prevention of cerebral palsy, and we lack data on all these different areas from low and middle income countries, other name of which is majority world countries. So that's another advantage, long-term impact through the key informants in terms of advocacy. And with the multidisciplinary team developed this through this field work and register setting, they can work as a national and international advocate, as well as doing new research, initiating new research on relevant sides of cerebral palsy and its effect on children and parents. That brings us to the next issue of resources that we have. So a lot of the work, initial work, was done through the partnership of CSF and London School of Hygiene and Tropical Medicine, and more recent work with cerebral palsy. It's done with the University of Sydney. Cerebral Palsy Alliance provided a huge support to the work to develop the register in Bangladesh, and subsequently now supporting and facilitating this global LMIC register. So throughout this process, we try to document whatever we learn during the community work, whatever we learn by delivering, implementing, establishing these projects. And all these resources are now available in the London School website using the key informant method. This is a big booklet guide, a working guide. We have a flip chart developed, which can be used for key informant training, and those things can be adapted for local context and local resources. And we have a document which provides further detail about how to set up a cerebral palsy register by using this key informant in the community. So thank you very much for your patience. That's all we wanted to share at this stage with all of you, but we have some time, and I would really appreciate some feedback from any of you, all of you. I understand that we have participants from wide range of countries. So, and especially a big participation, I think, from Lebanon. If they would like to share their ideas or plans and whatever they have kind of found interesting in this webinar and where we can utilize or take it further. At least one country from, I think Argentina is doing some recent interesting work. They can also share their ideas. Any other countries who are currently doing similar or slightly different methods you're using, please share. And any detailed question, you can still put that on the chat box. We will compile them and we will send a short document with links and discussions related to that to all participants. So the floor is now open for everyone. Please unmute and share your comments and opinions. Who wants to go first? Brazil or Lebanon?
I can go. I'm Abir from Lebanon, Abir Masad.
Thank you,
First
Abir.
of all, thank you for this really interesting webinar. For me, it was really helpful, and I believe for the whole team, because it has been a long time that we were struggling to create a registry for our population in Lebanon, since we don't have national surveys, we don't have an appropriate health system, and we lack of data. So our team, we work in an institution, it's a Zobel institution. We work with more than 1,400 children per year with disability, but still we lack of data. I think with this webinar, we will be able just, it's really helpful just to help us to start with a pilot study maybe, to collect some data from our community and from our institution. So it's really helpful, and I believe we will keep in touch, and we will need your support to launch this project.
Thank you very much, Abid. Thank you.
Yeah, thank you.
Next, who would volunteer?
Yes, if I may, maybe
Yes, please, Dominic.
I put my okay, thank you. Maybe I put my camera on so that you can put a
Yes, we can see you.
face to who is talking. Thank you so much, Prof. Moid, Prof. Gulam, and all the others. I'm Dominic Enyama. I'm from Cameroon. I'm a child neurologist, actually working in Douala, one of the main cities of the country. And we are going through a process to set up a cerebral palsy register here in Cameroon. So all these talks are very helpful. Some are new to us. So actually what we are doing is that we just have data from our institutions, our hospitals, and that's the reason why I asked the question to setting up a cerebral palsy register. Is it better to have data just from the institution? You answered, but we find it maybe a little bit challenging to go to the community to get in touch. But I think we will try. We will train ourselves first to the method, and then probably with a team we will try, even if it's in a small area, to start and to see how it goes. But yes, we really thank you for this opportunity, and definitely we are going to try our best here. So, thank you.
Thank you very much, Dominic. Anyone else? Please volunteer and share your. It's always good to know what we are all facing working at the hospital or in any other program, and what are the main challenges. It's also helpful to share.
Prof. Mohit, may I
Sure.
just interrupt that? Again, extremely sorry that this Mentimeter didn't play very well. So I think while we have some time, I think one of the questions in Mentimeter was, do you think you can implement KIM in your setting? So I can see that the chat option is working. So if you could write yes or no, so it will give us some idea, and we can discuss based on that. So do you think the key informant method to identify children with cerebral palsy in your setting could be used? Yes or no?
And meanwhile, Gulam, can you update us how many cerebral palsy registers are working at the moment in LMIC, and how many of those are using key informants? Rough idea.
Yeah, I think that's a wonderful question. So I can see that certainly Malawi has been a champion in Africa, and in Ghana, Samuel is here, and he is considering that, but Ghana has been institution based. In South Asia, we have in Bangladesh, in Nepal, Indonesia, we have used Kim, and very recently we have used in Fiji and in Vanuatu as well.
Okay.
I can see Ruby from Suriname is here. So Ruby and Tim actually was initially involved in Kim. But Ruby, would you like to share your experience, how it worked in Suriname? Because I think for Suriname, it was institution based. But Argentina is certainly considering Kim, but they're still institution based.
Right.
Hi, everyone.
Sure.
Yeah, I am sorry, my camera doesn't work. I am Ruby from Suriname, and here we are currently looking into how Kim can be used in Suriname. For the CP register, we are still looking into it, but I know that another organization used the Kim for another research. I think it was in children with cognitive problems, and they used the method and it worked. The results aren't published yet, but we're working together with the organization to see how we can also use the KIM for data collection of the CP register. But the current results of the CP register are only the hospital-based of the academic hospital in Suriname.
Yes, thank you, Ruby. And I think that paper has been accepted and published at the Development Medicine and Child Neurology. So well done, Team Suriname.
Thank
I'm
you.
curious to know what happened in Malawi. How did they find 500 children?
Yes,
Is that
Prof. Mohit, I
through
was just
other
going to.
systems, existing systems?
Yes, I was going to Aaron now. Actually, I think he has been
Mhm.
instrumental with Thembi.
Right. Okay.
So, Aaron, if you could share your experience, actually, what magic did you do? 10 Kim and over 700 children.
Well, thank you so much for the wonderful presentation.
Bit louder, please.
I hope you hear me.
Yeah, we can hear you.
Oh, thank you. Yes, well, as Tembi has explained earlier, we followed the steps that have been presented here. At first, we mapped our community, the referral system, the facilities where we would refer our children with various problems, and we approached various officers. Since we did this at one district, so we approached the officers at the district council. Mainly, we use the social welfare office. So this office, they allocated to us a number of volunteers who already work with children. So these are the health workers as well as the child protection workers. And these people, they already work their work day-to-day work involves handling issues to do with the children. So they already knew the vulnerable children who are in the community. So it wasn't very much problematic for us to work with them and for them to identify the children who are already deemed as vulnerable in the community. And we also added some who are like they are like chairpersons of community-based organizations which already work with these vulnerable children. So we work with people who work already hand in hand with the children in the various communities. So
Sounds like you have done the
them,
perfect him in Malawi.
yes. So we invited them for a day training, and we gave them the required resources, and we gave them an ample time for them to identify the children. It was about 8 weeks.
So this 10 key informants, they come from
Yes.
different groups and different departments, yeah?
Yes.
And then they go back and work within their department to spread it to other people. Is that right?
No, these 10 key informants, they already work in the communities.
Right, okay.
But in their day-to-day work,
yeah. But eventually, did you get the name through these 10 people or from various departments? Or
No,
from various departments via these 10 people?
No, we got all the list of children through these 10 people.
That's amazing. That's wonderful. The most effective key informants. Very high rate. No, that's important to know, because in every context, and I will comment on two things. One is, it is always normal to, when we work in the hospital setting, on rehabilitation setting, the idea of taking this whole team into a remote village and doing these camps, it's challenging, and also mentally it's initially there is a barrier. So like any other research or study, always you can do a small pilot project. And before even doing that, while you're mapping the local social and administrative structure, as mentioned in the Malawi project, that you can find effective social welfare department, effective health workers, they're already there. So if you do the mapping properly, you will find the right key informant, and a small number of key informant can be very effective and bring a lot of children. If your mapping is not giving an insight into the social structure and administrative structure, then your key informant system may not work. So it's very important to take time and do the mapping, and do a small pilot project in one sub-district or one unit. Other thing is, whether you are doing that or not, you should definitely, if you're in a hospital setting, you should definitely try and utilize the existing system and gather data, identify children from the walk-in patients. If you are in a rehabilitation setting, you gather data. So there is no harm in starting gathering data from the institutional sources before even going to the community. And then once you go to the community, do a small pilot project, you will learn a lot, you will see the challenges in a smaller scale, and then you can roll out to make bigger programs. That would be my suggestion. A lot of people answered that, yeah, they think it can be used. Some of you already are using it in different style and format. That's good. More request for more resources. Yeah, that's all I get. Stigma is a major barrier, some mentioned. Okay. Any comment from Gulam?
I think we have Mbapa on the line. I can see Mbapa is in an interface where Mbapa and team is seriously considering Kim to start the CP registry on their setting. So I think now, Mbapa, would you like to share what is going in your head now? Like, what would be the challenges you'll face in your setting? If you can introduce yourself and just share what you think.
Prof, thank you for this opportunity, and thanks to Prof Mohit for this very enriching webinar. I'm currently working to establish a cerebral palsy register in Cameroon with Dr. Dominique, and we have two phases. The first part is mainly institutional based, where we'll be recruiting from main hospitals and rehabilitation centers working with children with cerebral palsy. And the second part, which will take place in the latter stages of the project, we'll be using the KIM in a particular health area to start. It's more like piloting in the Boya health area, which we best understand the structure, and we are going to roll that out here and see how we can make it stable. From there, we can try to expand. I think the organizational structure of Cameroon is quite good. We already have these institutions, rehabilitation centers littered around our communities. And we hope to use the method that was used in Malawi with great success. Secondly, we already have community health workers in these communities, so we are going to link up with them. So we are optimistic about it. For now, we are still trying to bring up a team, so much so that we don't just go out and do a one-time thing. We are looking at creating a dynamic database. So we need stakeholders on board who will be a great part of the sustainability of this database. And here in our presence, I'll again acknowledge the presence of Dr. Dominique, a neuropediatrician, who will be supervising the project. So we have a great team and we are optimistic about it. Thank you.
Thank you, Dominique.
Thank you.
Oh, thank you, Mbappe, and of course, Dr. Dominique. Prof. Mohit, would you like to make any closing remarks? And I think
No,
before
actually,
that,
I would like to invite Nadia for the closing remark, and then you can close the session after Nadia.
I think unfortunately Nadia had to leave because she's on call.
Okay.
And
right.
I think she just left 5 minutes ago.
Oh, okay.
She thanked
So
all
that's
of
good.
us
All right.
for this wonderful show.
Yeah, I think that's pretty much it. And just to remind everyone, can you see the slide now?
No.
No?
Not yet.
Okay.
Not yet.
But yeah, just to remind everyone that the reason we're here is not about the data. It's not about the study methodology or key informant method. The primary reason we all are here is because all of us, we have experienced in our own setting that there are many, many children who are suffering because of cerebral palsy, because they are not detected, because they're not receiving any services. So we would like to do something about it. And this is just one initiative of that kind where we are working together to reach those children, whatever method works in our own context, and we would share and learn from each other and do more together. So saying that, I would like to thank all of you for your patience and for attending this webinar. And I would like to invite Gulam for his closing remark and to close this session. Thank you very much.
Thank you, Prof. Mohit and Mahmudul, and also Ishrat, who has worked behind the scene to make this great webinar possible. I think those who have used KIM or those who will be using KIM, as Prof. Mohit mentioned, is an extremely pragmatic method. It's not a blueprint, rather actually is an open method that where you use your imaginations and your local knowledge to make it work in your setup. I was just thinking one power of this, that we have seen that there were 39 participants at some point in this webinar, and many of you are using KIM and have seen success, and some will be using. So one action moving forward is that can we create a KIM user group or KIM working group where we can connect you all through that, so you can share your experiences as Aaron and Thembi did in Malawi, and Samuel is trying to do it in Ghana or doing it in a different way in Ghana, and which is working, and Mbappe is trying in Cameroon. So those things actually could be extremely powerful, and I'm certain though Prof. Mohit and others who have started that in early years probably were a bit lonely in that journey. So I think probably you will have a lot of colleagues and peers to support you and share experiences. So that's just one comment from my side. And I think hope Ishrat and Mahmoudul can take it on board as well. And this GLM CPR webinar series, this is our second one, and I can see that it's extremely well received. And thank you all of you for that. We have 4 more to go this year, and the next one is in a month time, and we'll be talking about cerebral palsy, early diagnosis and intervention in resource limited settings. And our speaker would be Dr. Kathy Morgan from Cerebral Palsy Alliance, and Mahmoudul will be there as well to share his experience. I would like you to share that with all of your colleagues and co-workers, and also for you, because I think it's in a monthly basis we are organizing these webinars. So it will be really encouraging if we see all of you coming back in these webinars. And before we call it close to this great session, I would like to take a group photo for our website, as we always do. So if you could turn on your camera, please. And Ishrat knows a trick how to take a snapshot or screenshot, so we can share with you.